एक बार स्लाइड मोड पे डाल।
Good afternoon, everyone. I, Dr. Shubhami Mittal, Additional Associate Professor in Anatomy, and as an organizing secretary, welcome you all back to the post-lunch session. We are proud to introduce our next speaker for this segment, Dr. Omkar Auti, who is not only an accomplished professional but also an UG alumnus of our very own Nair Hospital. He is highly respected consultant radiologist and cardiac imaging specialist, currently serving as the Cardiac Imaging Fellowship Director at Ruby Hall Clinic, Pune. He is passionate about and specialized in advanced cardiac imaging techniques, including cardiac MRI, CT angiography, and CT MRI for congenital heart diseases. He has authored multiple chapters for books and has more than 15 publications in peer-reviewed journal in his credit. He is an executive committee member of Indian Association of Cardiac Imaging and member of European Society of Cardiology. I invite him to share his insight on imaging anatomy of heart and coronary arteries. Welcome, Dr. Auti, sir, all the way from the Pune. Thank you.
Dr. Omkar is a 2005 batch student from Nair. Okay, so welcome him.
Thank you, ma'am, for the kind introduction. Good afternoon, everyone. Good afternoon, everyone.
Good afternoon, sir.
Thank you for waking me up, because it's quite hard, to deliver the lecture in the post-lunch period. So I try my best to not bore you and share some interesting details over here. Okay, so we start with the imaging anatomy of the heart. So what we are seeing over here, let's look at the overview of the heart, that you all must know that this is a 4-chamber structure to start with. It's very simple. There are 2 atria and 2 ventricles. Okay, so the atria are the smaller chambers, ventricles are the larger chambers of the heart. So atria acts as a receivers of the blood, and ventricles act as a Okay, so atria acts as a receivers of blood. Either it is from a systemic circulation or a pulmonary circulation. Ventricles acts as a pump of the heart. Okay, so that will pump the blood into this either systemic or the pulmonary circulation. So this is the anatomy topic and why I am telling about the physiology. But this always go hand in hand. So radiology, if you want to know the radiology, you have to know the anatomy for starters, and you have to know the physiology also along with. Okay, so this is the schematic diagram of the heart, where you can see the larger chambers are the ventricles, the smaller chambers are the atrium. These atrium are the receivers of the blood. Are you able to see my cursor?
Yeah. Cursor.
Cursor, I think
Cursor is not able.
just put that pointer.
Okay, so these are the ventricles, which are the pumping system of the heart, and these are the atria, which are the receivers of the blood. So on the right side, it has a right atrium and the right ventricle. They are connected through the valve, which is called as tricuspid valve. Next slide. So on the left side, it's a left atrium and a left ventricle, which is connected through a valve, which is called as mitral valve. Okay, excellent. So what is the blood from our systemic circulation, the deoxygenated blood that comes through the superior vena cava from the suffix, and from the infix through the inferior vena cava, and they go into the RA. From RA, the blood drains into the RV, and RV gives the blood and pushes the blood into the main pulmonary artery and enter in both the lungs to get the blood oxygenated. So once the blood gets oxygenated, it will come through pulmonary veins on either side. So usually there are 4 or more pulmonary veins. There can be, at minimum, there can be only 2 pulmonary veins, one on the right and one on the left. And they drain the blood into left atrium. So from left atrium, it goes into the left ventricle, and left ventricle pumps the blood into aorta to supply it to the entire body. Clear? So this is how the heart looks in a cadaveric specimen. You must have seen in your dissection, on the dissection table. And this is the heart we can reconstruct more or less similar to the real specimen on the CT image. So this is the CT images which are reconstructed into a 3D model, and we can look like this. But are the CT images are like this? No, these are just black and white images, right? So once you do the CT, the images will be something like this. Okay? So these are the cross section. We call these as a cross sectional views. So you cut across the body, whatever the part you know imagine over there. So this is covering only the heart part, and then you cut across the body, cross sectional to the long axis of the body. So that's why whatever images you are seeing, these are in a cross sectional view. This side is the right side, though it is on the left side when you see it. But if you see it from the feet point of view, this is the right side and this is the left side. For any radiological image, when they are presented in a standard format, this is the right side and this is the left side. Okay, so we are now going to see the imaging anatomy of the heart. What we are going to see is first connections. Like I told you, atria are the receivers, they receive the blood from veins, then it connects to the ventricles, and ventricles are connected to the great vessels like aorta and pulmonary artery. That we call it as a AV and VA concordance. Okay. Atrioventricular concordance. So when your right atrium is connected to the right ventricle, that is a good concordance, right? If that doesn't happen, then that's a discordant anatomy. Okay. So when your right atrium is connected to the right ventricle and the left atrium is connected to the left ventricle, it is AV concordance. Okay. Similarly, when your MPA arises from the right ventricle and aorta arises from the left ventricle, so that is VA ventriculo-arterial concordance. Clear? So we are just seeing the connections over here. Then we'll see about the systemic venous drainage. We should make sure that the systemic veins are draining into the IVC and SVC, and then they drain into the RA. The pulmonary venous drainage, it normally drains into the LA, left atrium. Then we see the morphology of chamber. Why we are discussing so much about the right ventricle and left ventricle? If there is a chamber, that's enough, right? But no, there are some characteristics of this chamber which makes them unique or which makes them special to do their own work. So we will see a little bit about the morphology of chambers. And at last we'll see the coronary artery anatomy. Okay, so for that, I'll have to take you to the actual viewing platform. So this is the CT image. This is the X-ray like image. You acquired it first on CT scan. Then you do the plain CT scan just to look at any calcium in the coronary arteries or the normal. Then you push and dye, which is iodinated contrast, and then you do this imaging over here. So this is your CT scan. Okay, so now we'll see the imaging anatomy in detail. So whatever we have studied. So these are the actual images of body, right? So what we are going to do, as you know now the connections and the connections within the heart, and you know how the blood flows within the body. So if you have imagined, you have given the you have put on the vein flow in the antecubital vein, and then you have given the iodinated contrast to it. So whatever the iodinated contrast, it looks like bright as in this image. Okay, so this is a bright contrast that you are seeing. This is the contrast what you are seeing. So just imagine the flow of the blood from the antecubital vein. Okay. So this side is left or right? Left. You are able to see my cursor, right? Okay. So the vein flow is put on the left antecubital vein. So now you can see this bright blush of the contrast over here. Okay, so can you see this blush of contrast? So we'll follow this contrast. Okay, so it goes into the, from the antecubital vein, it will go into the cephalic and then subclavian vein, right? From the subclavian vein, it goes into the left brachiocephalic vein. So you are seeing here anteriorly left brachiocephalic vein, which joins together with the other side of the right brachiocephalic vein to form SVC, yeah, superior vena cava. So this is your superior vena cava that goes and drains into the right atrium. Okay, so if you follow that right atrium inferiorly, then you will see a IVC over here. Okay, and then this right atrium is connected to which chamber of the heart? Right ventricle. So this is the right ventricle. You can see the position of this right ventricle, which is anterior. So when you hold the heart specimen in the anatomical position adjacent to the dissection table, you have to hold it in the anatomical position, right? Where you see the right ventricle anteriorly and left ventricle posteriorly. So similarly, this is the right ventricle anteriorly, left ventricle is posterior and left to that, and the posterior most chamber is your left atrium. Okay. So from right ventricle, the blood goes into the pulmonary artery. So this is your main pulmonary artery over here, and this is right pulmonary artery, left pulmonary artery, and then blood is given to the pulmonary circulation. Then again the heart receives the blood through pulmonary veins. So these are the pulmonary veins over here. This is on the left side 1 and 2. This is on the right side 1, 2 and 3. Okay, so there are 5 pulmonary veins in this case, and they are all draining into the posterior most chamber, which is a left atrium. Okay, and the left atrium is connected to left ventricle, and then again it gives the blood into aorta. Yeah, this is the aorta. So if you see the relationship over here, that the aorta arises posterior to the main pulmonary artery. As you have seen in the specimens, that the main pulmonary artery is the anterior most, and then the aorta arises posterior from it, and then it arches on the left side. Okay, so if this is confusing, we can see this in multiple views. Okay, so if you are not comfortable with the axial scan, you can see in sagittal scan over here, or you can see in coronal scan over here. Okay, so if you see in a physiological point of view, then your relations, if there is an anomalous pulmonary venous connection, then you will come to know when, if you follow this, stepwise manner, if you see the CT scan. If you just see the random images, then you will certainly miss most of the prominent anomalies. Okay, so I can rotate this image in whatever way I can. You can see that as I am rotating the axis, the image is getting rotated. So I can see the aorta in full picture over here, arising from the left ventricle on this side. On this side, I can see the aorta in other views. So here is the right atrium and the right ventricle I can see in other views. Okay. So what is the main advantage of a CT scanner? That it's a volumetric image. So you can rotate around the image, you can play around it, you can make some 3D recons, you can say make some MPRs or MIP reconstructions over here, and you can see anatomy in very much detail. Okay, coming back to our presentation. Okay, so now we have established the connections. Now we'll see the morphology of certain chambers. So how to differentiate the right atrium from the left atrium? So what is the difference between the two anatomical differences? First of all, the right atrium is connected and receives the blood from SVC and IVC. Okay. Similarly, left atrium receives blood from lungs. Okay. So when you are assessing, let's say, abnormal anatomies, and there is, not a proper, or there is abnormal systemic venous connection, there is abnormal pulmonary venous connection, connection. How to identify which is the right atrium and left ventricle? The answer is in the appendage of the ventricle. Okay, so atrium. So each atrium has an appendage, which is also called as the auricle or appendage. Okay, so if you see at the right atrium, the appendage is triangular, it is broad based. So appendage is triangular and it is broad based over here. This is the right atrial appendage. On the other hand, the left atrium has a finger-like appendage with a pointed tip. Okay, so usually it covers the left circumflex coronary artery anteriorly. So this is the main difference between the two atria according to the morphology. Okay, next there is something called as the crista terminalis over here. Okay, so the crista terminalis is a ridge. It connects the IVC and SVC junction with the RA. Okay, so it's a fold of tissue between IVC, SVC and the RA. So it runs through the entire length and you can see like this as a mass. So why this is very important to know, that sometimes on echocardiography you will see that either is this a mass lesion or is this a thrombus or is this normal structure, because the crista terminalis is not present in all the individuals, right? So crista terminalis is an anatomical variant which runs posteriorly. So it is very important to know if you are seeing any mass lesion or thrombus-like lesion in this part, it is a crista terminalis. Okay. Similarly, on the left atrium, it is a commoding ridge, which is again fold of tissue. It's an embryological remnant in the left atrium, which is adjacent to the left superior pulmonary vein. Can you see over here that the fold of a tissue over there? Again, it should not be confused with any mass lesion or thrombus in here. And thirdly, the coronary sinus eventually drains into the right atrium. What is coronary sinus? That all the coronary arteries supply the blood to the LV and the heart, and coronary veins, they drain the blood supply from the heart and then they drain into the coronary sinus. So that coronary sinus is eventually connected with the right atrium. Okay. Similarly, the differences between the right ventricle and the left ventricle, as we know that the right ventricle receives the blood from RA. So now this is the reconstructed CT image that I showed you that you can reconstruct in any manner. So this is the same patient what we saw, and I have reconstructed the images in the manner to learn the anatomy, where here the right atrium is connected to the right ventricle and then the empty is arising from right ventricle, right? Similarly on the left side, left atrium is connected to left ventricle and aorta is arising from left ventricle over here. So if you see the differences between the two, the right ventricle is a thin wall structure, okay, and the left ventricle is a thick wall structure. So why it is made like this? Because left ventricle has to supply the blood to the entire body, right? That's why your left-sided pressures are more. The right ventricle has to supply the blood only to the lungs, nothing else. That's why your pressure system on the right side is low. Okay, so that's why the muscles of the left ventricle are thick muscles and the muscles of right ventricle are thin muscles. But let's say there is a pulmonary stenosis over there, and so what is pulmonary stenosis does? That it is an obstruction to the blood flow. So in that cases, you might have a RV hypertrophy as well. Okay. So how to identify a right ventricle in that scenario is presence of moderator band. Okay. So moderator band is a structure which is a muscular structure and it connects the septum on the RV side to the RV free wall. Can you see the structure over here? That's the moderator band and it is the characteristic of right ventricle. If you are seeing a moderator band in any of the cardiac chamber, that's the right ventricular cavity. Okay. And if you see, this is the short axis view of your ventricles. You are seeing that on the LV side, this is LV, this is RV. And on the LV side, you are seeing that the septum is smooth. Okay. And now you can see the septum over here. It's not very smooth. So there are multiple trabeculations over here. Okay. So the septum on the LV side, interventricular septum is smoother. and on the RV side, it is with the multiple trabeculae. On the LV, you are having these two prominent papillary muscles, okay, which are on the predominantly on the lateral wall. This is called as the anterolateral, and this is called as the posterior or inferior papillary muscles. So there are two prominent papillary muscles. On the other hand, in the RV, there are smaller papillary muscles. There are three papillary muscles, but this will not be like a bunch or not like a hypertrophied papillary muscles over here. And papillary muscles connect to chorda tendineae. Chorda tendineae connects to the mitral valve and tricuspid valve respectively. Okay, excellent. Okay, so as we see that there is a atrioventricular valves, which are tricuspid valve on the right side and the mitral valve on the left side. Then there is a pulmonary valve at the origin of MPA and aortic valve at the origin of aorta. Okay, so there are four valve structures. Out of that, only mitral valve has a two cusps. Okay, the rest of the other valves, normal anatomical, there are three cusps. Okay, so there are three cusps in aortic valve, there are three cusps in pulmonary and tricuspid valve, and in two cusps in mitral valve. Okay, so if you cut across this aortic valve over here, you are seeing this like a Mercedes sign. Can you see that? Okay, so these are the three cusps of aortic valve. That also you can see in much more detail. The posterior most cusp, which is adjacent to these are the atria, okay, right, left atrium and the right atrium. So the cusp which is adjacent to the interatrial septum, that will be a non-coronary cusp. Okay. Then anterior to that will be a right coronary cusp, and this will be a left coronary cusp. So there are three cusps in the aortic valve. The nomenclature is based on the posterior most adjacent to the interatrial septum will be named as a non-coronary cusp, and then right and left coronary cusp. Okay. So this is a different pathological aortic valve where you are seeing a lot of calcium. The bright thing is the calcium over here. You are seeing that these two cusps are fused with the calcium over here, correct? And this is a functionally bicuspid valve. So though this is a tricuspid valve, you can see that the two cusps are fused together. They will act as a single unit over here, and then this becomes a functionally bicuspid valve. So this is a big chunk of calcium in the central zone of the cusps over here. So why I'm telling you this? That the imaging is so advanced now, especially the CT imaging, that has to be performed before doing any TAVR procedure. Okay, so the TAVR is something called as you must have heard about the aortic valve replacement, right? It is surgically when you cut upon the sternum, you cut upon the aortic valve, you chuck out the old valve, and then you place the new valve over there, and then you are good to go. That's your surgical AVR or surgical AV replacement. Now it's a era of TAVR, which is a transcatheter aortic valve replacement. So you just put a catheter through your femorals, you reach the heart, and you just open the valve over there, and then that's done. There is no need to undergo the sternotomy and the entire surgical operation for that. And for that reason, the CT is mandatory before doing the TAVI to size it accurately, because you cannot go wrong over here. So if the valve is not perfect, if the valve is too small, then it will act as aortic stenosis. If the valve is too big, then there will be aortic regurgitation. So there will be a lot of complications. So your sizing has to be accurate. For that, you have to undergo CT angiography before any procedures like TAVR and TAVR. And for that, you need to learn about the anatomy in detail about the valves. Okay. So what is the importance of anatomy? Why we are so much stressing about the anatomy in this modern medicine? First of all, what are the importance of connections? So if, as I told you, how to look for the systemic veins and how they are draining. If they are anomalous, there can be bilateral SVCs. So very simple example of that. Let's say there are bilateral SVCs. One is going into the right atrium, other is draining into the coronary sinus and going into the right atrium again. So there is no shunt, but when the patient is admitted for some other reasons in ICU and you put up the central line on the left side, it will not give you the accurate right atrial pressure measurements. Okay. So again, if you find this is not a lethal anatomy, but if you find this, you need to report this so that the management of the patient will be better. Again, there are some other anomalies like interruption of IVC, duplication of IVC, which you can pick up when you see the systemic veins. When you see the pulmonary veins, you can pick up pulmonary anomalous pulmonary venous drainage. It can be PAPVC, partial anomalous pulmonary venous drainage, or TAPVC, which is a total anomalous pulmonary venous drainage. The obstructed TAPVC is rather a neonatal surgical emergency where you have to make decisions very fast within hours. So I told you about AV and VA concordance. There are multiple defects associated with this, which is tricuspid atresia or double inlet LV or double outlet RV. So double outlet RV is aorta and pulmonary, both are arising from the right ventricle. So if you are not thorough with the anatomy, you will not be able to make this diagnosis. So like there is a transposition of great arteries. The MTA is arising from LV and aorta is arising from RV. So that is a transposition of great arteries. So what is the importance of morphology? So when you are, I told you that the mass mimics like crista terminalis and comedy bridge that you should be aware of and not call it as a thrombus or mass lesion. In heterotaxis syndrome or complex congenital heart diseases, again it's very important to name that chamber, whether it's a morphological RV chamber or morphological LV chamber. That makes a lot of difference in the patient management. The other form is corrected TGA. So what is corrected TGA? I'll just take 1 minute on this. So corrected, as you have understood the AV and VA concordance, right? Okay, let's look at the AV discordant. What is AV discordant? If your right atrium is connected to left ventricle, okay, and the left atrium connected to the right ventricle, okay. In corrected TGA, the AV discordance is there, as well as there is a VA discordance. Okay, so what is VA discordant? That the aorta is arising from right ventricle and MPA is arising from left ventricle. So in corrected TGA, if you see the blood flow wise, the deoxygenated blood goes to the pulmonary artery, oxygenated blood goes to the systemic veins. There is no difference, correct? But what happens that there is change in the ventricle. The ventricles only they have changed the position. The right ventricle has come to the left side and the left ventricle has come on the right side. That's the only change. So this particular anatomy, and as your right ventricle is giving the blood to the systemic arteries, it is already hypertrophic. Okay, so you will not be able to make a diagnosis on the basis of muscle thickness only. So you have to know that there is a moderator band over here, and this is a morphological right ventricle, and this is a morphological left ventricle. So what happens in this patient? In this patient, there is no left to right shunt or right to left shunt or no shunt over there, no cyanosis or anything. But over a period of time, the right ventricle will not sustain the systemic pressure. Okay, so you have to act early in these cases. So these cases mostly they present in their late 30s or late 40s. Okay, so if you diagnose it early, then the management will be much better. Okay, and as I told you, there are multiple, like TAVR, there is TAMR also. You can replace the mitral valve through the catheter. You can replace the pulmonary valve through the catheter. So all these newer techniques, they need a good CT coronary, CT angiography reports in there for the accurate sizing of the valves. Okay, let's look at the coronary anatomy. Okay, to look at the coronary artery, we have to know aortic root anatomy in detail. So we know that now aorta is arising from left ventricle. Aortic valve is a tricuspid structure. Okay, there are 3 cusps in there. So your aortic root is the part where your aorta takes off. Okay, so the junction of aorta and the left ventricle is called as the aortic annulus. Okay, and this bulging part over here, these are called as the sinus of Valsalva. Okay, and the junction between, this is the ascending aorta, so the junction between ascending aorta and this aortic root is called as the sinotubular junction or ST junction. Okay, so there are 3 parts of aortic root: annulus, junction with the LV, sinuses, the middle bulging out part, and the ST junction which connects to the ascending aorta. Okay, so this is your pulmonary annulus. This is sinus of Valsalva. This is an ST junction. Clear? Excellent. So as we know that we can cut across any plane in CT scan, so let's cut across the pulmonary valves. So what you are seeing over here, that three cusps are there. So the posterior-most cusp, which is closer to the interarterial septum, is your non-coronary cusp, and then the anterior one is right, and on the left side it's the left coronary cusp. So if you cut across little more above the at the level of sinuses, you will see the origin of coronary arteries from here. Okay. So the right coronary cusp gives off the right coronary artery. The left coronary cusp gives off the left coronary artery. Clear? Okay. Let's again look at the radiological picture over here. Okay, so this is very important that you have a three cusps, and right coronary artery arises from the right side, the left coronary artery arises from the left side. But you must have heard that there are three coronary arteries in the heart, right? So the left coronary artery divides into the two, which is LAD, left anterior descending coronary artery, and the LCX, which is the left circumflex coronary artery. Let's look at this one. So I'm just scrolling through the images over here. Okay. So this is your left coronary artery arising from the left coronary sinus. Then it divides into the LAD over here, which is the left anterior descending coronary artery. So if you just follow the LAD, just follow this thread over here. So this is your left anterior descending coronary artery, LAD. It goes into the interventricular groove, anterior interventricular groove. So these are two ventricles, right ventricle and left ventricle. So the groove in that is called as the anterior interventricular groove, and the LAD travels in that groove. Okay, so I'll say in other words, so the coronary artery which is arising from the left coronary sinus is not a left coronary artery, but coronary artery which goes or which travels into the anterior interventricular groove is your left anterior descending coronary. Okay, that's why it is called as the anterior descending, because it's in the anterior interventricular groove. Okay, similarly the LCX or the circumflex coronary artery which goes into the left atrioventricular groove. Okay, so that's your LCX. And your RCA or the right coronary artery goes into the right atrioventricular. Clear? Okay. So again, these coronary arteries you can see in multiple planes. You can turn around and you can see in the entire thing. So if I want to show you the entire course of it. Okay. So these are the 3D reconstructions of the same patient, where this is the left coronary artery, left main coronary artery, which divides into the LAD, which goes into the anterior interventricular groove, and the LCX of the circumflex, which goes into the left atrioventricular. Okay. So the branches arising from the LAD, these are the diagonal branches on the lateral aspect, and the septal branches, these are the septal branches over here, which goes into the myocardium. Similarly, LCX has obtuse marginal or OM branches. Okay. So LCX gives off the obtuse marginal or OM branches. Okay. Okay. And this is your RC or right coronary artery which goes into the right atrioventricular groove, which further goes down and divides into the PDA or posterior descending coronary artery, which runs into the inferior interventricular. Okay, so there is an anterior interventricular loop, and then there is a posterior or inferior interventricular. The PDA runs into the inferior interventricular, and this is the PLV, which is a posterolateral ventricular branch. Okay, so this is how the entire circle is formed. This is your RCA, this is your LAD, this is your LCS. So this called as the circle and half loop model. This gives the blood supply to the entire heart from all the sides. Okay, so what is left coronary artery or what is the right coronary artery? It is not the coronary artery which arises from the right side always, but when it runs into the right atrioventricular loop, it becomes a right coronary artery. Okay, and the LAD goes into the anterior atrioventricular. Okay, so this PDA is a little special branch, so which runs into the inferior interventricular loop. So sometimes it comes from the right side, RCA, or sometimes it comes from the circumflex side. Okay, so when it comes from the right side, we call it as a right dominant circulation. When it comes from the left side, we call this as a left dominant circulation. So more than 70% of the people, they have a right dominant circulation. Around 18-20% people, they have left dominant circulation, and around 5% population will have co-dominant circulation. Okay. So this dominance, the decision of the dominance is based upon the PDA arises from where, right? Okay, and as I told you, the course of coronary artery determines the nomenclature. We have seen the diagonals and the septal branches of the LAD, and the branches arising from L6 are called as the obtuse marginal branches. Okay, so why I was saying that the course is really important, and these are some schematic images of the coronary artery anomalies, where here you are seeing that your left coronary artery arising from the right cusp, here your right coronary artery arising from the left cusp. Okay, so the origins can differ in anomalous cases, but they follow the same path. So if it travels into the right atrioventricular loop, that is your RCA. Okay, sometimes the coronary artery also can arise from pulmonary artery. That is called as the AL kappa. Okay, not going much into the details of it. So this is one aspect of your coronary angiography to assess the anomalous courses. The most important aspect of the coronary angiography is to assess the stenosis or blockages in the coronary artery, which are responsible for the heart attack and sudden cardiac death. Right? So these are the different tools we have at our workstation, which includes a 3D model. This is called as the MPR view, where you can see from start to end. This is the LAD picture over here. Start to end, you can see the straighten view, you can see the cross-sectional view, so as we can determine if there are presence of any plaques, which is a soft plaque or calcified plaque, and how much obstruction, how much stenosis it is causing to that vessel. So CT angiography, again, this is a non-invasive investigation. It's an OPD investigation. There is no need to admit the patient. With the newer CT scanners, we can do at any heart rate up to 120. So it's literally walk-in test for anybody. You can finish the test in 10-15 minutes, and you can have these lovely images with you, and you will have the entire data of your coronary artery blockages or stenosis in there. Clear? So CT, we do. What are the indications of CT? One, we saw that the congenital heart diseases, to define the anatomy, define the morphology of chambers, to define the connections, to define the shunts. Okay, that is for the congenital heart disease. For the adult one, to assess the coronary artery disease, to assess the coronary artery anomalies in detail. These are the two prominent features of CT scan. Now we move on to the cardiac MR anatomy. Okay, so MR is little different technology where the images are taken by exploiting the magnetic properties in our body. Okay, so it is not volumetric images like CT. Like CT, you have seen that just one data is there. You can manipulate it, you can rotate it, you can do whatever you want to do. On MR, it is a multi-planar imaging. You can take images in any plane, but you have to do it on the machine itself when the patient is in the magnet. Whereas on the CT scan, you do the CT scan and you can assess the images whenever you want, right? On MR, when the patient is within the MR gantry, you have to take images at that point, right? Okay, so this is how a typical MR study will look like. There are so many sequences. In CT, you just saw that one plain phase and one iodinated contrast phase. That's it. But there are too many sequences. Maybe the images are less in here, but too many sequences to handle. Not again going into much into detail. So these are just as we saw the anatomy of the heart at various axial planes. Similarly, we can see on MR. This is the black blood images where you can see your structures like it. These are 4 chambers, the RVOT, LV, and the pulmonary arteries over here. So this is the 2-chamber view. So why we have to, again, what I told you that you have to take the images in there. You cannot, acquire from top to bottom everything. You cannot manipulate it later on. So that's why there are some structures or some views defined. So these views correlate with your echocardiography views. Okay. So you take the planes in certain angles so that you can acquire the images in that specified time with you. So this is called as the 2-chamber view. So we can call this as an applied anatomy. Okay. So this is the 2-chamber view in here where you are seeing the left atrium and the left ventricle. Okay. So these are the cine images where you are seeing the left atrium and this is the left ventricle. Can anyone tell what this is? You are seeing this little structure over here. Are you able to see that small little structure going in front, which is a characteristic of left atrium?
Auricle.
Yes, excellent. So this is the left atrial auricle. You can see that it is finger-like and it is pointed, right? Okay. Similarly, this is a 4-chamber view. Again, it's very simple. Why this is called as 4-chamber view? Because you are seeing 4 chambers over here. So there are 2 atria. This is the left side, left atrium, right ventricle, and the left ventricle. Okay. So these are 4 chambers over here, and the wall between 2 ventricles is called as the interventricular septum.
Finish this now.
The wall between 2 atrium is called as the interatrial septum. Simple. Okay. So here you can assess the function of right ventricle and the left ventricle as well. Can somebody tell that what is this structure over here, which I am pointing out? You are seeing some muscular-like bands over there.
Moderator.
Moderator band. Okay, excellent. So this is the moderator band which runs from the RV side of the septum to the free wall. Okay. So this is the short axis image. When you cut across both the ventricles, you will get this image. Okay. So in this image, this is the LV and this is the RV. Again, the wall in between the both ventricles is called as the interventricular septum. Can somebody tell what are these structures over here? These 2 points?
Capillary.
Papillary muscles. Yes, as we saw on that CT image, that there are 2 prominent bulky papillary muscles in the LV. Okay, so this is a 3-chamber view. Why it is called 3-chamber? We are seeing 3 chambers, 3rd chamber as being aorta. Okay, so this is LA, this is LV, and this is the aorta arising from that. Okay, in this way you can see the function of mitral valve over here. If there is a mitral stenosis or mitral regurgitation, you can assess that also. You can, on MR, you can assess LV function in the sense what is the volume of LV, what is the stroke volume of LV, what is the end systolic volume in the LV. That entire thing you can assess on the cardiac MR. Plus, if there is a mitral regurgitation, you can also assess that how much ml of MR or mitral regurgitation it is going into the image. Okay, so that is called as the regurgitation fraction. Similarly, if there is AR, you can assess the regurgitation fraction of AR. Okay. So this is a mitral valve and this is an aortic valve. Okay. So this is again LVOT view in a different aspects where you are seeing the LV and the aorta arising from LV. So these are the standard views we take in cardiac MR because we cannot take the cine images for the entire plane. So this is the RVOT view where you are seeing the MPA arising from RV over here. Right? So why this is a RV? Why this is not LV?
Moderate.
Look at the wall, the moderator band you are not able to see over here because this is not in that. But if you see that wall thin, it's not thick wall.
Ah.
Again, this is anteriorly located.
Ah.
So the anterior most chamber is your arm.
Right.
And this the valve between it is pulmonary valve. Okay, so there are lots of other images of MR that we need to assess. We can assess the infarction, infiltration. So main MR, why we do it? To assess the myocardial status, to characterize the myocardium. So let's say there is a coronary artery disease that we have assessed on CT, and the patient had MI the patient had MI. So we don't know what is the effect of that coronary artery disease. So effect of that we assess on MR in terms of infarction. We can see that which wall is the affected by infarction and which is not. Okay. So for that, to have to have a better understanding at it, there is something called as the 17 segment model of the heart. Again, these are not anatomical planes. These are made by us for us to categorize the LV much better. So left ventricle is divided into the basal cavity, which is more towards the mitral valve. Okay. The mid portion of the cavity is mid cavity. The more towards the apex we go, that is the apical cavity. Okay. And the terminal portion is the apex. Okay, clear? So we are taking a representation of this mid cavity over here and apical cavity over here. You draw the line from the RV insertion point. So this is the RV. This is superior RV insertion point. This is the inferior RV insertion point. You just draw two lines from there, imaginary lines, and then you will divide this entire LV into 4 walls. Okay? So the superior most wall is called as the anterior wall. The septum is called as the septum. The posterior or inferior is called as the inferior wall, and the other wall is called as the lateral wall. Okay, so this divides into the lateral wall. But if you see, this is the basal and mid cavity. If you see that this segment is too large a segment, right? So you just cut across and put an imaginary horizontal line through it, and then it is further dividing into the other segments. This is called as the anteroseptal because this is anterior wall, this is the septum. Similarly, inferoseptal, very simple, inferolateral and anterolateral. Okay, so the 6 segments in basal cavity, 6 segments in mid cavity, 4 segments in apical cavity, that is 16, right? And 17 segment is your apex. So this is again an anatomy which is not there per se. If you take out this specimen cadaveric heart over there, you will not find these segments. But this we have made for ourselves to make our life easier and convenient. Okay, so take home points. Well, it is very important to know the cardiac anatomy. If you are reporting cardiac MRs or CT, you need to know about the connections. You need to know about the morphology. The coronary artery nomenclature, again, it depends on where the coronary artery courses or where it travels, not on the origin of coronary artery. The dominance is determined by the posterior descending artery, whether it's arising from the right, left, or both the vessels are giving the PDA. The coronary artery anatomy is really important in assessing coronary artery anomalies. The cardiac MR has a different anatomical model. There are certain particular views that we take to assess the cardiac MR, and 17 segment model is that we have constructed for our sake of time. Thank you. Any questions?
Amazing.
Anybody has any questions?
Number सांग. मागच्या वर्षी नापास झालं तर 16 नंबर. मागच्या
Thank
वर्षी
you,
16
Dr.
नंबर नापास
Omkar,
झालं.
for explaining the anatomy of the heart in such a beautiful and such a simple way. In fact, you've done a better job than us as anatomy teachers, where you explain first the cardiac chambers and then the coronary arteries, And I must say it was a special experience to sit on the other side of this room. I've always been on this side with you being on the other side, but to sit as a student for attending the lecture of one of my students, it was a very proud moment, and thank you so much for it.
Thank you.
And I think we should give him a very loud applause for the way he explained it. It was really very, very simplified. So I think since we have recorded it, students, when you are revisiting the anatomy of heart, when you are learning the thorax and heart, you must revisit this lecture because it will help you understand all the 3D. In fact, it will make you understand it in a 3D way, right? So thank you so much, and we would like to felicitate you with, where is Aarti? Yeah.
Thank you so much, ma'am, for inviting me. And
Our pleasure. Absolutely, absolutely. Thank you.
And this is a bit of nostalgia for me because on these benches, not literally on this because these are renovated. At our time, these were different benches, but in this particular hall, we have, learn anatomy over here. That was the main hall. This was the side hall. Some lectures used to happen over here, and the main lectures over here. So it is really fantastic. It is a very loving feeling, coming to your own institute, and you are invited into the own institute. So thank you so much for inviting over here.
Thank you, sir.
I invite Dr.